Good morning, everybody. On behalf of the organizing committee, I welcome you all for this interesting CME on cardio-diabetology. All of us know medical science is a rapidly advancing field, where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession. Today's program will cover several issues on cardio-diabetology, and they will be addressed by a galaxy of speakers of national and international repute. I request all the delegates to post their questions in the chat box, and I'm sure the proceedings of the conference will contribute immensely towards better patient care. The first session is on hypertension, and our opening batsman is Dr. Rajeev Agrawala. Dr. Rajeev Agrawala is very close, near and dear to us. He is currently the chairman of Department of Cardiology at the Saumitra Ray Specialty Hospital, Meerut. He is an amalgam of preventive cardiology as well as invasive cardiology, which is a rare combination. He has received several awards and orations, as you can see on the screen, and his department implants free pacemakers for needy people and holds the Limca book of records for implanting the maximum number of free pacemakers in India. His clarity of expression leaves behind an everlasting imprint on the minds of the audience. I'll hand over the session to the chairpersons to conduct this session. Dr. Balbir. Dr. Balbir, please start the session. You are mute, Dr. Balbir. You are mute, Dr. Balbir. Dr. Balbir, you are on mute, yes.
Yeah. I unmuted already. Yeah. Good morning, ladies and gentlemen. The first speaker is Dr. Rajeev Agrawala, who is going to speak to us on current and future perspective in management of hypertension. As we all know, there are over 1.1 billion cases of hypertension today in the world, and more than 60% of people over the age of 60 years are suffering from it. The number is rising, and we need more and more medicines. And he's going to tell us what are the medicines which are available today and what are the medicines which are likely to be used to treat the hypertension in future, their advantages, disadvantages. So without further delay, I'll request dear friend Dr. Rajeev Agrawala to start his talk. Dr. Rajeev Agrawala, please.
Thank you, Dr. Balbir. Thank you, Dr. Manoria, for such a warm welcome. It is my responsibility. Whatever faith Dr. Manoria has put in, I have to live up to his expectation. I welcome all the audience. Let me make it very clear. I'm not going to revise the guidelines in my presentation. Dr. Manoria asked me to make a presentation regarding the perspective. So everything which I am going now in next 18 minutes is going to be futuristic, current information. Let me tell you, I'm going to show you data which is just being brought out in last 1.5 years or so. So you will have fresh air in my presentation. As you know, historically, Stephen Hales, who was a priest in a church, measured blood pressure for the first time, and the measurement of blood pressure was 8 feet 3 inches of water. That is how we measured. And after 250 years, despite measuring blood pressure, we were not sure that whether to treat blood pressure is good and not to treat blood pressure is good. And this is one quote from British Medical Journal. They said that's very great danger that if somebody measures your blood pressure, because after that he will try to reduce it and it will kill a patient. So that was too extreme innovation and then poor understanding. And we are becoming wiser every day what is blood pressure. Still, we are not the wisest on that front. Let me sail you through one of the recent Nature review, which talks about lifestyle intervention for prevention and treatment of hypertension. Then they have talked about myokines in the genesis of blood pressure. Myokines are special chemicals or cytokines which are released from the muscles. I am not going to detail about the biochemistry of that, but what I am going to talk about that Western civilization and Western lifestyle is a very important cause of blood pressure. There are several populations in world which still live the primitive or the olden style like Hazda, Simane, Shuar, Kitawa, Yamogani, which still have the old lifestyle, and you find, unlike rest of the world, which have rise in blood pressure over a period of time, these population without any intervention continue to have blood pressure lifetime less than 120 and diastolic pressure less than 80. So that is too simplification, but still implies that whatever we talk in next couple of minutes should not dilute the basic instinct and basic desire on the part of treating clinician that lifestyle modification is very, very important component of blood pressure management. So non-westernized population vis-a-vis westernized population, which is one of the very important causes of blood pressure, processed food, hypercaloric diet, high sodium to potassium ratio, and very important thing is irregular sleep-wake cycle. In fact, we are all suffering because of that. Our interface with the Western world, Europe and United States become more on commercial, educational, and personal front, and the time zones are clashed because of high dependency on IT industry. So cardiac synchrony, circadian synchrony is very important, and we should try to live as simple life as possible, and we should not forget in very important. Somebody just said obesity runs in your family. The answer is nobody runs in my family. So obesity is a very, very important cause of hypertension. I'll run through and not talk about 130 is majority of the guideline talk about. That is the blood pressure we recommend, and this is what we have latest. What is interesting to know that diabetes mellitus, whatever you have, still the guidelines suggest that the blood pressure should be 130/80. I'll say, remember this slide. I'll use this slide again in subsequent part of my presentation and tell you why it is important to learn this slide. The general recommendation is whether your risk is high or low, the targets remain same. To my mind, that is the biggest blind spot in management of hypertension. I will develop on it later in my presentation. If the blood pressure, if the patient is young, we can go down to less than 120, but not less than 120. Again, I'll take this information forward in subsequent presentation that less than 120 is not a good goal, and only thing is up to 120 if it is tolerated, and this is especially in young people, not definitely in people who are 80 years or more or 65 to 79 years. So not less than 120. I'll say why it is so. We know that drug combinations are good, dual dose combination in smaller doses, full combination, triple combination. And let me tell you, if you are dealing with resistant uncontrolled hypertension, the first drug or the fourth drug is spironolactone. Never forget. So you can use a combination of chlorthalidone with spironolactone. You are not supposed to place chlorthalidone with spironolactone. They all go together. So this is the fourth drug if you are not handling with, if you are not able to control blood pressure with ACD. Another very good study which has come very recently, all literature suggests that bedtime treatment improves the outcome, but we don't have that direction from guidelines. This is a yet another blind spot. I think guidelines have to take challenge that this information is incorporated in times to come. Patients who are given bedtime drug are doing better than patients who are given early morning pill, and you know the reason is circadian rhythm. We have early morning surge in blood pressure, and that has to be controlled. And now this IGI study suggests that it is good time if you are giving one pill, use it longer acting pill, use it one time. If you are using two pills, then there is no problem. Give one in the morning, one in the evening, and this has shown the stroke is less, coronary events are less, cardiac events are less, minor events are less. Bedtime dosing of drugs is better than awakening time. How I look at management of hypertension, SPRINT is my favorite trial, and this is one trial which showed that aggressive control of blood pressure up to 120 is better than a conventional control.
There's some problem with the line.
Of us know the blood pressure management. SPRINT shows very favorable outcome, 27% reduction in mortality, 38% reduction in heart failure, and CV mortality reduced by 43. Even in frail individuals, more than 75 years, aggressive treatment was better. If I combine SPRINT and ACCORD, look at non-fatal myocardial infarction, aggressive control or intensive control does not result in benefit. Stroke, which was very big outcome contribution in ACCORD, although the study was done in diabetes and was not positive study, but trends were favorable. Surprisingly, in SPRINT, there was no stroke benefit. So this is yet another blind spot that intensive control should have controlled stroke, but we did not witness. Heart failure is reduced in SPRINT, but not in ACCORD, and combined results are favorable. SPRINT and ACCORD primary outcome, when they are combined, they are better. So this is how we look that when we combine intensive treatment, these two trials, probably we do better in heart failure and primary event reduction. But it doesn't come without cost. The acute injury in SPRINT was higher. So the bottom line is defined as I told you, not less than 120. The SPRINT patient have acute kidney injury. So unlike lipidology, where there is no bottom, the bottom in hypertension trial is defined by acute injury. If you reduce it further, then probably the acute injury will define the J curve. And that is how we are not supposed to go less than 120, because acute injury incidence keeps on increasing. That's why the BP management has got a bottom, unlike lipidology. The another concept which I want to pass on is the SPRINT data, which shows that if you have polyvascular disease, aggressive control of blood pressure is better. PAD with intensive control do better than PAD without aggressive control. So like lipidology, we are trying to learn that the vascular risk of the patient should determine the intensive or conservative treatment, because if the vascular risk is high, probably intensive treatment does better. I am going to present another study, which is a SPRINT study outcome and response of blood pressure management with albuminuria and eGFR. As the estimated GFR keeps on increasing, you know the heart failure incidence is low, but on a lower side, the heart failure increases. Similarly, on the heart failure and CV death increases on lower GFR, we know it is cardiovascular risk factor. Similarly, if the albuminuria increases beyond 330 to 300, there is linear increment in heart failure. So is the cardiovascular death and heart failure. When we do intensive treatment, we know up to 60, it does well. Intensive treatment 60 and above is beneficial. This is how we look at it. It is beneficial. But if you are less than 60, intensive treatment may be hazardous. So like any other anti-diabetic drug, if you are trying to focus on 120 kind of thing, do take care of eGFR. Similarly, if your albumin levels are low, intensive treatment is high. If your albumin levels are more than 300, then intensive treatment may be hazardous, and you have to look for upcoming renal injury. So this is not a blind approach. You have to be conscious what is the baseline eGFR or albuminuria. Then the issue of diabetes, we know every parameter, CV death, MI, stroke, everything is high in diabetic. But for the same blood pressure, diabetics are at higher risk. So a patient who is non-diabetic, 140, his risk is lower than a red patient, which is diabetic. So we have a trial data that diabetics do less good. Unfortunately, the guidelines do not discriminate diabetes and non-diabetes. This is yet another very recent study, and which was a meta-analysis, and it showed that whether the patient has CV disease or no CV disease, if you reduce blood pressure, it gives advantage. So 5 millimeter risk reduction in systolic pressure is benefit. And in these patients, if you have CV disease, the and recruitment was 146 by 84, and if there no CV disease, it was 157 by 89. That means these were stage 1 hypertensive. And this is the kind of plot you can graph. You can see that as the amount of or the volume of BP reduction increases, the gains, they increase. And this is a very famous quote by Professor Kamlesh Kunti. And this is a unification approach, that as we decrease events with lipids, similarly for every 5 millimeter mercury of reduction at 4 years, there is 10% CV events. This is not absolute, this is relative risk reduction, and you can make out that the curve in secondary prevention following CV disease is steeper than cardiovascular disease. So it is not equivalence. The relative risk reduction is different in two populations, but the risk reduction is same. That means 10% in both the population over a period of 4 years. This is HOPE-3 study extension, and what it showed that this is an intermediate risk patient, and if you give rosuvastatin, the curve separates up to 5 years, and this is a withdrawal and just a legacy effect of statin. You see they continue to diverge. And BP reduction, they were more or less normotensive patients, 130 to 143, and patients who were 131 to 143, they were not benefited by reduction of blood pressure, which was 6 by 3 millimeter by candesartan and chlorothiazide. But if you have higher pressure, they are being benefited. So message is that we are touching within the normal range. The reduction is not beneficial, and these are intermediate risk patients. They are not polyvascular risk patients. So don't confuse what I showed in SPRINT and with this patient. And let me tell you another thing. SPRINT was a high risk vascular population. You will be surprised to know the Framingham risk score, average risk score of Framingham patient was 21. So it was almost secondary prevention. It was not a garden variety of hypertension, which you see in your clinic, simple young hypertensive, no comorbidity. So SPRINT should be very carefully applied to your clinic patient, that they are high risk patient. And what you see when these two things combine, blood pressure reduction and rosuvastatin, there is additional risk reduction with combined therapy. And that is how, when these drugs were left over and there were follow-up, just simple passive follow-up, the curve continued to diverge, suggesting that probably hypertensive medication with statin have a legacy effect. Even KDIGO guidelines in renal failure have suggested a blood pressure of less than 120. But definitely you have to be cautious about upcoming worsening of renal failure, what SPRINT has shown. How I synthesize this? The management of risk factors should be unified. They should not be in isolation, which unfortunately is the case in hypertension management. Unlike lipids, you know, in lipids, we talk of everything. So our goal in lipidology will be, if you have diabetes, if you have a stroke, if you have albuminuria, If you have polyvascular disease, your LDL will be different. It is not same for every patient, but unfortunately, if my patient has got diabetes, he has got hypertension, he has got stroke, then there is nothing like this which combine multiple comorbidities, and that is probably the reason why we are facing problem. You know, the LDL strength or reduction of LDL level keeps on increasing depending upon the risk. But as I told you, we still talk about diabetes mellitus, chronic kidney disease, heart failure in isolation. But what we have in clinics is diabetes with chronic disease, stable ischemic disease. There are multiple comorbidities existing together. We don't have that guidelines existing with us that if your risk is more, probably aggressive blood pressure lowering is the way to go with a bottom of 120 systolic blood pressure.
Dr. Agrawal, 2 minutes left.
Okay, yes, sir. I think that is the message I want to pass on, that define vascular risk of your patient, and if the vascular risk is high, probably aim for an aggressive blood pressure lowering like lipids. And finally, I am going to touch upon the Mendelian randomization studies of lipidology, which has got the steepest curve. And then I am going to present the Brian Ferentz data that lifetime reduction of systolic blood pressure along lower LDL-C is far more beneficial than one parameter alone. They did a natural experiment, and since I don't much have time to explain you how the natural experiment is done, but if you combine both the things, then lifetime risk reduction is 80%. So if we reduce the LDL and the BP, then risk reduction is enormous, and longer we do it, better it is. And Dr. Ferentz has said that they are independent, additive, and dose-dependent effect. If you lower 1 millimole of LDL and 10 millimeter of mercury for lifetime, there is 80% risk reduction and 68% lower lifetime risk of CV death. So that is how the curves are plotted. And that is another piece of information that ESC guidelines suggest. If your patient has got BP more than 180 and 110, irrespective of comorbidities, these patients are called high risk and they need intensive, moderate intensity statins. And I think this is least practice in our day-to-day practice. They don't need aspirin, they need statin. Calcium score is another way to look at it, risk factor approach. And calcium, if you take into account along with blood pressure, like patient who have 140 to 160, if your calcium score is 100, then NNT is 5. And if the risk is more than 15, and calcium score more than 100, the risk is again 5, meaning thereby, if you do calcium scoring, then Framingham risk scoring loses its impact, because calcium score is the indicator or the footprint of the disease. It is not a risk factor, it is a disease. And another way to look at it, if you want to define whether my patient will be benefited by aggressive or intensive BP lowering, probably calcium score will come that way. Calcium score correlate with the events. This is a recent paper by Dr. Khurram Nasir, just published in BMJ, showed that CAC-based personal risk management, especially in diabetes, is very, very important, because high-risk patients, they need aggressive BP lowering, and that is the way forward. Ladies and gentlemen, I feel that we need to define vascular risk of the patient and then practice sprint-like blood pressure. I am just towards the end of my presentation, and as you know, Apple Watch has become a standard tool for detecting atrial fibrillation. Recently, I come across this seat advertisement for this seat, which shows that you can measure heart rate, SpO2, and blood pressure and weight by sitting on this seat. I think that is going to be the future of management of hypertension, because this is the basal state. You can measure blood pressure. I feel this innovation has to be practiced. It is right, remote sensing device, and our patients can be better managed on heart failure and blood pressure management. And it's like domiciliary blood pressure management in situations, and we can use this data in up titration of the dose. So I am just ending my presentation. Lower is better as we apply in lipids. Longer is better as we apply in lipid. Earlier is better. We have to define the high risk phenotype to get the higher yield and chase sprint-like blood pressure management. Unfortunately, the care in hypertension is compartmentalized, not composite. It takes risk factors and comorbidities in isolation, not in cluster, with the result, if we try to apply the sprint pressure in a very low risk patient, it will not be an economical way to do it. But in a high vascular risk patient, if we reduce the blood pressure sprint way, I'm sure we are going to transfer that benefit to our patient. So ladies and gentlemen, I'm just going to show you, you have to have the holistic view. Guidelines are just one direction, and you have to apply your mind, take another 360 view. What is the way to look at these guidelines? Because then only we will have a complete picture. We continue to be the student throughout life so that we try to help the community as much as possible. And this is my last slide, which is a very famous quote from Marilyn Monroe: imperfection is beauty, madness is genius. It is better to be absolutely ridiculous than absolutely boring. I do not know how much I have been able to make an impact on you, but I'm sure I was not boring, and it must have incited you for some new understanding and new pattern of practice of management of hypertension. Thank you very much.
Thank you, Rajeev, for your wonderful talk. Is there any time left for discussion, or should we go
Yes,
to the
2-3 minutes. You can ask 2-3 questions.
Yeah, it's open for discussion. Any questions, queries, please go ahead. By co-chairman, please.
Dr. Rajeev, lowering of blood pressure is commonly associated with decrease in the incidence of stroke. But why the paradox was there in the sprint trial? Or is it that the blood pressure was so much lower that there were more strokes? What is your comment on this?
I actually don't have the answer. In fact, Dr. Cushman was in my town, and we had this talking to this, because that is what is the understanding, that stroke is one entity which is most benefited by aggressive control of blood pressure. But unfortunately, it's difficult to answer you that what is the precise mechanism. But the bottom line is strokes were not reduced in this sprint. I can't answer you specifically, but it's a fact.
Dr. Rajeev, could you please comment upon how to treat extreme dippers? We do come across patients, who have very low blood pressure in the evening time, and they have pretty high blood pressure in the morning. So how to go about such patients?
I think you have to compartmentalize your drug, and the ambulatory blood pressure is a very important tool in management of hypertension. Guidelines are now more and more advising for follow-up management. Then you have to divide your dosage, and you reduce the evening dose, maybe you build up a morning dose.
And also in patients with postural hypotension, which blood pressure recording should we consider? Is it the BP measurement at sitting position, or when they are made to stand after 3 minutes? What should be the target of blood pressure control?
Yeah, postural hypertension is to be diagnosed in a conventional way, and you have to readjust the drugs, look whether they are overused, hyponatremic, and these are the things you have to look. And postural hypertension continue to be one of the major denominator for titration of the drug. That is
Dr. Rajeev Agrawala, this is Dr. Asha Murthy from Chennai.
Yes.
I have a question for you, that a patient who's coming with a vasculitis, a small vessel or medium vessel vasculitis with a hypertension, in such what are the drug of choice which is better suited for these patients? Because they have a lot of fluctuations, they have a lot of lability of in the blood pressure, and we have come across some of the patients which have been documented by the MRA. So uncontrolled pressure and they found they have a vasculitis, diffuse vasculitis.
Conventionally, beta blockers are avoided if you have peripheral arterial disease. I'm not talking of vasculitis at the moment, but the newer guidelines says super selective like bisoprolol kind of drugs can be used in even peripheral arterial disease. In fact, there is less incidence of MACE if you use this. Regarding vasculitis, there is no specific drug design. Only thing is you have to keep titrating drugs, and if there is too much of sympathetic drive, whatever guidelines may say, beta blockers are definitely a big help in reducing those fluctuations.
I think with
Thank
this,
you.
we conclude this session and move on to the next session. The next session is on antiplatelet therapy. Has time come to say bye-bye to aspirin? The chairpersons for this session are Dr. Rohit Modi, Dr. Sangram Bradar, Dr. Prabhat Pandey, and Dr. Harendra Kumar. The speaker for this session is Dr. Pankaj. He is a Chief Interventional Cardiologist at the Manoria Heart Care Center, Bhopal. He has 10 years experience in the field of invasive interventional cardiology. He is fellowship of Society of Cardiac Angiography and Interventions, fellow of American College of Cardiology and ESC. He has expertise in radial angiography and angioplasty, several publications in various journals, past editorial secretary of ISJ, and is widely published report. I'll hand over the session to Dr. Modi to conduct this session. Dr. Modi, please.
Thank you very much, Dr. Manoria. First of all, I must thank you because you selected me as a chairperson, and thank you also for giving very nice introduction of your son Pankaj. So it has lowered my work. I straightway request Pankaj to go ahead with the subject. Has the time come to say bye-bye to aspirin? Pankaj, please.
Okay. So good morning to all the chairpersons, faculties, and all the attendees. I hope my slides are visible and I'm audible and visible too.
Yes, sir. Yes, please.
Okay. I've been assigned a very interesting topic, though it's very controversial. Has the time come to say bye-bye to aspirin? And I'm sure at the end of my talk, I will ignite a lot of discussion and controversies for sure. But let's see. Aspirin is a wonder drug. I accept it, no doubt. Since the discovery by Bayer in 1898, it was hailed as magic, and for good reasons. And it has used to be one of the most commonly used antithrombotic drugs, and it has saved millions of lives. I accept it. But with time, science changes. If you look at the headlines of this newspaper, on 15 July 2015, it says that aspirin at bedtime can save your life. But the same newspaper, after 3 years, published this headline as a danger of daily dose of aspirin. This is why I say change, and the science keeps on changing. Change is a law of nature. But why this change has happened, let's see. Now, if you see, again, the question comes, has the time come to say bye-bye to aspirin? Now, if we look at aspirin usage, we use aspirin in basically 5 categories of patients. First, in the primary prevention of atherosclerotic cardiovascular disease. Second is a secondary prevention of acute coronary syndrome. Third is a secondary prevention in chronic coronary syndromes. Then fourth in stroke prevention and atrial fibrillation. And finally, as a part of triple therapy in atrial fibrillation in a patient who had a CAD and ACS undergoing PCI. I'll touch upon each of these categories and I'll tell you that time has finally come to say bye-bye to aspirin. Primary prevention of aspirin. We have been using aspirin for primary prevention for decades. But of late, about 2 to 3 years back, 3 trials came which have digged the graveyard for aspirin as a modality for primary prevention. And these 3 trials, started with the word A. They were Ascend, Arrive, and Aspire. Now, if you look at these 3 trials, the Arrive trial was done in patients with moderate cardiovascular risk who had for primary prevention. Aspire trial, SP trial was done in elderly individuals. They didn't have any risk factors, whereas Ascend was done in diabetes patient. Now, if you look at the Arrive and SP trial, there was no benefit of aspirin in prevention of cardiovascular death, MI, and stroke. Even in the presence of moderate cardiovascular risk factor, in the Arrive trial, you can see the colliding graphs, there was no significant benefit. But there was some benefit seen in the diabetic subgroup in the Ascend trial. But when we look at the safety of these trials, all these 3 trials, the Arrive, Ascend, and the Aspire trial, clearly showed that there was a significant increase in the bleeding, both major and minor bleeding. Even the GI bleeding was more. Clearly, you can see both in the Arrive, Ascend, and Aspire trial, the divergent graph, p-value was significant, clearly suggesting that the hazard of using aspirin was much more than the benefit. So if you look at based on these trials, the recent guidelines have almost omitted aspirin to be used as a primary prevention modality. If you look at the 2016 ESC guidelines, it says that antiplatelet therapy is not recommended. It's a class 3 recommendation. The only recommendation they have suggested for aspirin and primary prevention is if there is a patient of diabetes who has multiple cardiovascular risk factors, having high chance of any ischemic event. At the same time, there are no bleeding risk factors. This is the only category of patient which aspirin is found to be useful. Otherwise, it's a class 3 recommendation. If you look at the ESC guidelines for CVT prevention, it clearly says that the low dose of aspirin should not be administered for primary prevention. So it's clearly that. So finally, is the time come to say bye-bye to aspirin in primary prevention? Almost, I can say, with one exception, that it can be used in patient with diabetes, with multiple cardiovascular risk factors, and young age, and no bleeding history, and no bleeding diathesis. This is the only category of patient in which aspirin for primary prevention is viable. Otherwise, it's time to say bye-bye to aspirin for primary prevention. Now, what about secondary prevention? We use aspirin after acute coronary syndrome and after doing PCI. But again, in the recent evidences have tried to omit aspirin in the treatment armamentarium. Various aspirin discontinuing strategy from the DAPT have tried this approach, means they have omitted aspirin after a particular time. Some trial have omitted after 1 month, some trial have omitted after 3 months. They have omitted aspirin and they have continued only single P2Y2 inhibitor, that may be ticagrelor or clopidogrel. These were the trials: the global trial, global leaders trial, GLASSY trial, Twilight, Stop DAPT, Smart Choice, and TICO trial. All these 3 trials were based on the principle that after a certain period of time, we may omit aspirin. Aspirin may not be required and continue only single antiplatelet therapy, and see that whether this strategy reduces bleeding. At the same time, the ischemia may not increase. Based on this concept, all these trials were done. And if you take all these trials together, the meta-analysis, you can see clearly saying that all the studies are shifting toward the left side of the graph, meaning only monotherapy. Left is means monotherapy, and the right means, if you see the right means aspirin plus P2Y2. So only P2Y2 therapy was found to be monotherapy was found to be useful in reducing the bleeding outcome. You can see all these trials have come up with a common message that if you omit aspirin, you reduce bleeding, no doubt. At the same time, there was no increase in the risk of MACE. That means aspirin is not required after a certain period of time. If you omit aspirin, you reduce bleeding. At the same time, the MACE is not increased. So clearly suggesting that aspirin may be discontinued after a certain period of time, after acute coronary syndrome and after doing angioplasty. Even if you look at the recent 2020 guidelines, they have said you can omit aspirin, continue only with single P2Y2 inhibitor after 3 months if the bleeding risk is high, and it's a class 2A recommendation. So even now the guidelines are endorsing this fact that you can discontinue aspirin and say bye-bye to aspirin as early as 3 months, or in some case as early as 1 month after acute coronary syndrome undergoing PCI. So the final, this I think we have discussed. Now, I have told you we have discontinued aspirin after 3 months or 1 month, but now we have moved one step further also. So do we need aspirin at all in acute coronary syndrome? And can't we say bye-bye to aspirin immediately after acute coronary syndrome? So this is going a step further. And this strategy was tested in the Gemini ACS1 trial. In this trial, what they did was they gave, in acute coronary syndrome, they gave P2Y2 inhibitors to all the patients, be it clopidogrel or ticagrelor, and they stopped aspirin as early as 10 days after acute coronary syndrome, and they continue with rivaroxaban. There were 2 arms: P2Y2 with rivaroxaban and P2Y2 with aspirin. And this strategy was tested with the view that omitting aspirin and adding rivaroxaban early in the phase of acute coronary syndrome, is it safe? And what they came to the conclusion that there was that clinical significant bleeding was same whether you use aspirin or rivaroxaban along with the P2Y2 inhibitor. This is the first step to test whether this strategy is safe or not. Another next step in this trial is a PART-2 trial, that is a Gemini ACS2 trial, will be an efficacy outcome trial. And this strategy will test that omitting aspirin and adding rivaroxaban instead of aspirin along with P2Y2 inhibitor in patients of acute coronary syndrome, can we reduce ischemia? We know that bleeding is not increased with Gemini ACS1 trial, but this Gemini ACS2 trial will test that stopping aspirin as early as within 10 days of acute coronary syndrome and adding rivaroxaban instead of aspirin along with P2Y2 inhibitor, can we reduce MI and can we save more lives with this strategy? So we are looking at saying bye-bye to aspirin as early as within 10 days after acute coronary syndrome. So now the third category of patients in which we use aspirin is chronic coronary syndrome. We know that we use aspirin in patients with stable angina, post-MI 1 to 2 years, post-CBG, longer patients, and post-CVAs, we use aspirin. We have been using aspirin, and it has been endorsed by guidelines. Yes, you have to use aspirin in case of chronic coronary syndrome. It's a class 1A recommendation. I agree to that. But again, I will reveal various newer evidences which has come up, and it says that if you replace aspirin by either clopidogrel or other P2Y2 inhibitor, this strategy is not only safe, but it is more efficacious in reducing future MIs and saving more lives. This strategy, I go back, I'll take you to 1996 in this important paper published in Lancet, that is the Capri trial, in which they compared that in chronic coronary syndromes, whether aspirin strategy is better or clopidogrel. And what they came to the conclusion in that trial, 1996 trial, the Capri trial, that clopidogrel was better with a significant p-value of 0.043. This interpreted that long-term administration of clopidogrel to patients with atherosclerotic cardiovascular disease, mean chronic coronary syndromes, was more efficacious than aspirin in reducing the combined risk of ischemic stroke, MI, vascular death, and overall safety was equal to aspirin. So clearly suggesting that clopidogrel is as safe but more efficacious as aspirin in chronic coronary syndrome. So why not say bye-bye to aspirin in chronic coronary syndrome also? There was a meta-analysis again published last year also only, in which they compared the monotherapy with P2Y2 inhibitor, means clopidogrel versus aspirin, for secondary prevention in patients with established chronic CCS, that means established chronic coronary syndrome. Again, if you look at this meta-analysis, it clearly suggests that if you use clopidogrel instead of aspirin, you reduce MI more. That means protection of MI is more with clopidogrel monotherapy versus aspirin monotherapy in this meta-analysis which was published recently. Now I'll take you to the third evidence suggesting that aspirin may be omitted in chronic coronary syndrome is a very recent trial, that is the host exam trial, which was published, which was discussed in the recent ACC meeting about few months back and was published in the Lancet thereafter. The trial was a host exam trial in which what they did was, after giving a dual anti-platelet therapy for 1 year or 18 months, depending upon the type of patients, once the patient landed up in the category of chronic coronary syndrome, they divided the patient into monotherapy of aspirin versus monotherapy of clopidogrel. This is what we wanted to test. So in a patient of chronic coronary syndrome, they compared aspirin versus clopidogrel, and the primary endpoint was a composite of death, non-fatal MI, stroke, and the bleeding also. There was almost, you can see, a 27% reduction in the primary endpoint with a very significant value, clearly indicating that the clopidogrel monotherapy is more useful than aspirin monotherapy in chronic coronary syndrome. When they look at the secondary endpoint of thrombotic events, clearly suggesting almost a 32% reduction in the thrombosis event, MI, and ischemic stroke with clopidogrel when you use clopidogrel versus aspirin. In fact, the bleeding was also less. Once we use 32% reduction, the bleeding also when you replace aspirin with clopidogrel monotherapy in chronic coronary syndrome. So with this evidences coming up in chronic coronary syndrome, so I think why not, it's time to say bye-bye to aspirin in chronic coronary syndrome also. The fourth category of patients in which we use aspirin is for stroke prevention in atrial fibrillation. Now, if you look at the guidelines, it clearly said that aspirin usage only for just stroke prevention in AF patient regardless of stroke, is a class 3 recommendation. That means that you are harming more. So if in a patient of atrial fibrillation, you are just using aspirin for stroke prevention, you are doing more harm than good. So clearly it's a class 3 recommendation, should never be used. Now, another category of patient of atrial fibrillation who had an acute coronary syndrome and who have to do a PCI. In this category of patient, aspirin is used. Now, so whether it is justified to use aspirin in patients of atrial fibrillation who had an ACS and undergoing PCI, and this modality was tested again about 6-7 years back in the VOICE trial. This is the first trial which tried to replace aspirin, which tries to omit aspirin in this triple antithrombotic therapy. And they came to the conclusion that this red is the triple therapy and black is the double therapy. So once you use triple therapy, means aspirin plus clopidogrel plus warfarin, vis-a-vis you use only clopidogrel and warfarin, you reduce bleeding by almost 64%. At the same time, there was no increase in the risk of death, MI, and stroke. So clearly suggesting that if you omit aspirin from the triple therapy and give only a dual therapy of one NOACs or one anticoagulant plus one antiplatelet, you reduce bleeding without increasing the ischemic risk. The same strategy with NOACs trials, a number of NOACs trials have come up with this in this category of patients of CAD and atrial fibrillation undergoing PCI, and this strategy of omitting aspirin was tested in the Pioneer F trial, Redual PCI trial, Augustus trial, and Antrus AF PCI trial. In all these trials, one thing was common, that dual antiplatelet therapy was better than triple antiplatelet therapy. That means omitting aspirin from the triple antiplatelet therapy, you reduce the bleeding significantly. This is again a sub-analysis of the Augustus trial, in which they studied that on top of dual therapy, that means on top of clopidogrel and apixaban, if you add aspirin, whether you reduce ischemic events and whether you increase bleeding or not. Then on the left side of the graph, you see, as compared to the placebo, if you add aspirin to NOACs plus clopidogrel in AF and PCI, you do not reduce ischemic event. P-value is not significant. But at the same time, if the bleeding was 89% more, hazard ratio 1.89 means there was 89% increase in the risk of bleeding if you add aspirin to already NOACs plus clopidogrel in AF and PCI. So no benefit of adding aspirin, you do more harm and good. So it's clearly time to say bye-bye to aspirin in this category of patient also. Even in the recent ESC 2020 guidelines, they clearly says that you have to use you have to use a triple therapy only for 1 week and to the maximum only for 1 month in high ischemic subgroup of patients, and you have to omit as soon as possible. You have to remove aspirin from the triple therapy and continue with only a single P2Y2 inhibitor and a NOACs, which is as sufficient to reduce the stroke also and reduce the ischemic coronary events also, at the same time reducing bleeding to a much better extent than the triple antiplatelet therapy. These have been engrossed in the ESC guidelines also. It is a class 1A recommendation to omit aspirin from the triple therapy. So I've given you enough evidences in all the category of patients, whether it's primary prevention, whether it's secondary prevention immediately after acute coronary syndrome, whether it's chronic coronary syndrome, whether it's stroke prevention, or whether it's AF undergoing PCI. I think with this evidence coming, I'm sure that aspirin is going to lose its utility in all these categories very fast. And I'm sure, and it's really will be time that everybody will say bye-bye to aspirin and rest in peace, dear aspirin. Thank you.
Can I ask a question? Dr.
Yeah.
Pankaj, very nice presentation, I must say. Would you, your comments on in a patient post-menopausal lady, with tortuous coronaries and hyper sluggish blood flow, would you recommend aspirin as a primary prevention?
If there's an ectatic artery, sluggish flow, we need to give some amount of antithrombotic therapy. Now, a single antiplatelet therapy usually sufficient if there's no stenosis, only a sluggish flow. Now, the question comes whether to give in this category of patient, whether to give aspirin or a clopidogrel. There's no hard evidence in this category of patient, but we have evidence from the other trial that when we compare aspirin with clopidogrel was found to have less bleeding, number one, at the same time reducing future MIs and reducing other ischemic events was less with clopidogrel. So why not give clopidogrel instead of aspirin in this category of patients? MSc.
Dr.
Pankaj,
Pankaj Manoria,
Indian data.
this is from Dr. Asha Murthy from Chennai.
Yeah,
Good
ma'am.
morning, how are you?
All well.
It was a very nice and crisp presentation.
Thank you.
But actually, I don't agree with that. The aspirin should say bye-bye, because it can be safely combined in those patients with going primary PCI, and they are put on ticagrelol and aspirin for longer period of time. That is number one. Unless the patient has got a complication of bleeding diathesis or any history of bleeding GI hemorrhage. So primary for such patients, I think both combination dual antiplatelet with ticagrelol and aspirin is a very good combination.
Yeah, I agree. In the case of acute coronary syndrome, particularly primary angioplasty, all these trials have continued with aspirin and with the DAPT regime up till 3 months. After 3 months, and some in 1 month, they have tried to omit aspirin from this regime. So I agree that up to 1 or up to maximum 3 months, we have evidence that we can use along with the DAPT, along with the P2Y2 inhibitor, we can continue aspirin. But I will tell you, there are now ongoing studies in which as early as 10 days, they are trying to remove aspirin from this regime. That one of the trial was the Germany ACS2 trial, in which within 10 days they are giving single antiplatelet P2Y2 and adding rivaroxaban to the regime instead of aspirin. And they are trying to, they have already proven that it is safe to give this. And now they are trying to prove whether it is more efficacious in reducing the ischemic events, the Germany ACS2 trial. So I am sure that the limit of using aspirin from 3 months to 1 month, they have now come to 10 days also. They are testing this strategy also. So it's too early to say bye-bye to aspirin within first 3 months of acute coronary syndrome. I agree to that. 1 month we have some data, but I am sure with time to come, it is going to happen, because all these strategies are including that these other strategies are much better than saving aspirin. Aspirin was a wonder drug for years because there were no other better anti-thrombotic drug to compete with the aspirin. That's why.
Dr. Pankaj, this is Dr. Prabhat Pandey. Compliments for your nice presentation. Please let me know what in few of the conditions where you said that it was stopped after 3 months or 10 days. What dose of aspirin was used in those conditions?
Hello.
Those period. What dose of aspirin was used in those period?
Hello.
Am I audible? Hello.
Hello.
Am I audible, Dr. Pankaj?
Dr. Pankaj, is there any Indian data to suggest your evidence?
Hello.
Is some problem with
Dr.
audio?
Pankaj?
Hello,
Yes.
75 milligram aspirin.
Okay.
Yeah.
I think with this we conclude this session, and the next session is on VTE, demystifying the nuances of VTE in Indian context. The speaker for this session is Dr. Saumitra Ray, and the chairpersons for this session is Dr. Abhay Pandey from Dubai, Dr. Sudhakar Kancharia, Guntur, and Dr. Mrs. Lakra from Raipur. I'll request Dr. Pandey to introduce the faculty. Dr. Pandey, please. Dr. Abhay Pandey.
Yeah, I'm audible, I hope. This is a very, very important topic now with the advent of the newer direct oral anticoagulant drugs. The venous thromboembolism causes a lot of morbidity and mortality. To demystify this particular role of in VTE, we have Dr. Saumitra Ray, who is Director of Invasive Cardiology in Amri Hospital, Kolkata. He is a professor in Vivekananda Institute of Medical Sciences, Kolkata, executive member and ex-vice president of Cardiological Society of India. He has many, many accolades. He was first in order of merit in secondary MBBS and MD exam. Also, he has done MRCP, FRCP. Such a knowledgeable, highly educated person will guide us and will demystify this particular venous thromboembolism. I request Dr. Saumitra to take over. Dr. Saumitra, please.
Thank you, Dr. Pandey, for the nice introduction. Let me share my screen. Area. Thank you, Dr. Manoria, for inviting me. And I was just was amazed by Dr. Pankaj Manoria's presentation. It reminded me of your younger days, Dr. Manoria, sir. I am still a fan of your lectures there, and it's just reminded me those old days. Fantastic, like father, like son. Now this time, sir, you have bowled me out by a googly, demystifying the nuances of VT in Indian context. With my limited knowledge of English, I had to go back to dictionary to find out the meaning of the headline. Now, demystifying means clarifying. The nuances means finer shade of difference of meaning of a word. So simply it means that clarifying the meaning of VTE in Indian context. Now, of course, in Indian context, VTE for a general person means Victoria Terminus extension. Now, I need to clarify that in medical terminology, even in India, it means venous thromboembolism. So I think that's sufficient for my talk, and I have done justice to my subject, but I have 17 minutes to spare. So I will talk on the second meaning, that is venous thromboembolism in Indian context. Now, in whatever context, venous thromboembolism hinges on the vicious triad, which means why you should have thrombosis. If there is a problem with the coagulability of your blood, like cancer, thrombophobia, inflammation, if you have hemodynamic problem in your blood, like immobility, varicose vein, venous obstruction, or if you have problem with the conduits through which the blood is flowing, like surgery, chemical irritation, and inflammation. The venous thrombosis yearly incidence is very high, 1 per 1,000 person years. Many of them go unnoticed. And 1/3 of DVT actually complicate with a clot in the lungs. And the recurrence at 5 years is almost 30%. And the case fatality of recurrence is 3 to 6%. So it's a huge problem, but somehow it takes a second preference in our discussion because it falls in the borderline zone of cardiology and pulmonology and acute care medicine. So I am not sure how many cardiologists routinely treat pulmonary embolism or how many cardiologists see DVT in their clinic on a routine basis. Some of them are seen more by orthopedic surgeon, by gynecologist, then they are referred to physician or chest physician, and we cardiologists miss. So we are not very conversant with the day-to-day practice of DVT and pulmonary embolism. Now, if we see DVT by numbers, 96% they arise from the lower limb and only 4% arise from the upper limb. And that also there is a secondary cause like cancer, breast cancer, and so on. Of symptomatic lower limb DVT, 88% involve the proximal vein. The rest only involve the calf vein if it is symptomatic, because calf vein DVT usually go asymptomatic. Almost all lower extremity DVTs arise from the calf vein and extend proximally. So calf vein is almost universal. Then if it goes proximally above knee, then only we get more of clinical parallel the patient come, particularly with PE. And as the age increases, the number of DVT increases, particularly in male, particularly above the age of 65, male outnumbers female by a significant number. Indian perspective, there is a fantastic autopsy study by Kakkar and Vashisht, published 10-15 years ago, but they said that exact epidemiology of PE in India is largely unknown. An autopsy study showed the overall incidence of pulmonary embolism in patients admitted to the medical ward of a tertiary care center in North India was almost 16%, mainly affecting younger population of age below 50. The incidence of significant embolism contributing to the death of patient was 12%. So actually, if you go by autopsy data, it's a huge number. But I believe none of you will agree with this data because we don't see this. That means we miss almost 90% of this diagnosis. Patient comes in cardiac crash, we thought it's a cardiac arrest of MI, and the patient dies. We don't do autopsy as usual, and the diagnosis goes unnoticed. So if you do autopsy on a routine basis, you'll be surprised to know how high is the incidence. Now, why this high incidence? Who are the culprits? The intrinsic risk factor, the first and foremost, is a history of previous thromboembolism. Then you have a 15 times higher chance of another thromboembolism. And other things which have 2 to 4 times more risk are venous insufficiency, chronic heart failure, and obesity. And if you see the triggering factor, pregnancy causes 11 times more chance of thromboembolism, followed by 5 times more by general emaciation, immobilization, long distance travel, and infectious disease. Now, very recently, only 2 years ago, European Society of Cardiology published their guideline on pulmonary embolism. I think we have all read the chronic coronary syndrome. We have all read the lipid guideline, but perhaps not many of us have read the pulmonary embolism guideline. Again, because we cardiologists are not so interested in pulmonary embolism because we don't see in our day-to-day practice. But if you go there scrutinizing that guideline, it's a fantastic guideline where they have identified the strong risk factor with odd ratio more than 10 in fracture of lower limb, previous history of thromboembolism, spinal cord injury, heart failure hospitalization or atrial fibrillation hospitalization recent, hip or knee replacement, major trauma, and heart attack within 3 months. So you see at least 3 or 4 of these 7 factors relate to surgery department, either orthopedic surgery or neurosurgery. They do not come primarily to us. And there is a Wells clinical prediction rule for deep vein thrombosis, again, which give 1 point to active cancer, immobilization, bedridden condition, localized tenderness along distribution of deep vein, entire leg swollen, unilateral calf swelling, and so on, a conglomeration of symptoms and signs. If you have 3 or more points, then the chance of DVT is 75%, whereas only by 1 point less, if you have 2 points, then the risk is only 17%. And if you have less than 1 point, that means no point, then you have got 3% chance. So it's a huge difference between high risk and moderate risk, and moderate risk and low risk. Now I'll come to that later on. Now D-dimer is a very important and initial diagnostic test, but it is age sensitive. Below 50 years of age, your cutoff for normalcy is 500 microgram per liter. Above 50 years, it is age into 10. So a 60 years old man will have the cutoff of 600 microgram per liter. If we come back, if you suspect DVT and determine the pretest probability, as I said, the Wells criteria, if it is low, you do a D-dimer. Negative, no DVT. Positive, you do a compression ultrasonography. Negative, again, no DVT. Positive, yes, it is DVT. Now, if the possibility is moderate or high by Wells criteria, then you don't do D-dimer first. You do compression ultrasonography first. If it is positive, DVT. If it is negative, then you do D-dimer. And D-dimer, if negative, then it is no DVT. If it is positive, then you don't start treatment. You repeat the ultrasonography in a week's time. Now I come to the second part, that is thromboembolism. 1/3 of DVT complicate with embolism in the lungs. And who are the high-risk patient for pulmonary embolism? When the shock index is more than 1. What is shock index? It's your pulse rate by your systolic blood pressure. So if a patient has got 100 pulse with 100 systolic BP, his shock index is 1. But if his pulse rate is more than his systolic BP, he is high risk. If his oximetry shows below 95% oxygen, he is high risk. If echocardiography shows right ventricular hypokinesia or dilatation or tricuspid regurgitant pressure more than 40, then he is high risk. If there is troponin I or T positive, he is high risk, as also the BNP, NT-proBNP, and as I said, D-dimer level when more than twice the normal value. Now the imaging test, again, ESC has defined very clearly that computed tomography pulmonary angiography is readily available throughout day and night, excellent accuracy, strong validation in prospective management, low rate of inconclusive result, so the sensitivity and specificity are very high, may provide alternative diagnosis also, the ready at hand if you get something else, a cancer or something, short acquisition time. But its flip side are radiation, iodine contrast, then you can give in pregnant and breastfeeding ladies, or iodine allergy or renal failure, overuse because it is easily available, clinical relevance in subsegmental PE. In planar VQ scan, almost no contraindication, inexpensive, strong validation, but limitation is not readily available. It is more subjective and inconclusive test in 50% of cases. And VQ SPECT study is somewhat more diagnostic and accurate. Pulmonary angiography is still the gold standard, but not readily available, and it is invasive. The spiral of hemodynamic collapse, if you see, when there is a huge pulmonary embolism, there is increased right ventricular afterload with dilatation and tricuspid regurg, with neurohormonal activation, oxygen demand increases, right ventricular ischemia, contractility decreases, right ventricular output decreases, so there is less cardiac output and systemic blood pressure falls,
Recording in
coronary
progress.
perfusion falls, and ultimately it's a vicious cycle. So you have to see whether the patient is in shock, then it is high risk, no shock, no high risk. And the patient is present with cardiac arrest or obstructive shock with systolic BP below 90 or end organ hypoperfusion, then the patient is in shock. And right ventricular dysfunction, Dr. Vijay Lakshmi will tell more in the echocardiographic parameters of this if the questions come, the right ventricular dilatation, systolic dysfunction, and so on, and myocardial necrosis by troponin T and troponin I. As we said, the transthoracic echo parameters that in both parasternal long axis and apical fourth chamber, you can get the right ventricular dilatation, flattening of interventricular septum, distended inferior vena cava, with the ACT below 60 millisecond, and all this echocardiographic parameter of right ventricular stress. Indians, led by Dr. Jamshed Dalal, published a consensus statement 5 years ago. But they said that patients with acute PE should be immediately stratified as per the mortality risk by applying the clinical prediction criteria and the usual tests like ECG, chest X-ray, routine lab, D-dimer, compression tomography, CT pulmonary, etc. And as I mentioned, 2019 ESC guideline gave a very good algorithm that bedside TT, RV dysfunction, search for other cause. If there is a RV dysfunction, yes, you go for CTPA. If it is yes, you go for treatment. Suspected PE patient without hemodynamic, again, as I mentioned, you do the D-dimer test early and then the CTPA if it is a high risk probability. And depending on the clinical and the angiographic and the image criteria, you categorize the patient. If the patient is hemodynamically unstable, then he is high risk and go for immediate treatment of troponin test, then reperfusion treatment, monitoring, consider rescue reperfusion by either surgical embolectomy or thrombolysis. Now, what do you do if you think in high risk PE? That you immediately start anticoagulation with unfractionated heparin, and you consider systemic thrombolytic therapy. If the thrombolytic therapy is contraindicated, then you may go for surgical embolectomy. But if it is intermediate or low risk, you should not start with unfractionated heparin. Rather, you start with low molecular weight heparin or fondaparinux, and with oral anticoagulant, NOACs are preferred over VKA if they are suited. But NOACs are not recommended in patient with renal impairment, pregnancy, lactation, or antiphospholipid syndrome. Our newer oral anticoagulant, like in Einstein study, rivaroxaban was given 15 twice, and then they were given at 10 milligram once daily, 20 milligram once daily, and they were superior to warfarin. In recover trial, 150 milligram BD of dabigatran, and in amplify trial, 10 milligram BD of apixaban for 7 days. 10 milligram BD followed by the standard dose for 6 months. They are all superior to warfarin. And the Indian guideline was same, but another thing is that routine use of systemic thromboembolysis is not recommended with intermediate or low risk, but it is a good option for high risk patient. In Indian context, thrombolytic therapy is recommended in all high risk patient, in some cases of intermediate, but not in low risk patient. And there was a publication from Gangaram Hospital, pulmonary embolism frequent occurrence in Indian patient with symptomatic lower limb venous thrombosis, and they have given a very simplified algorithm, again depending on the probability whether the patient should be admitted or discharged from the hospital. Routine use of IVC filter is not recommended, it is class 3 and should be considered with acute PE and absolute contraindication to anticoagulation. So use is very limited. Now for long-term recurrence, if there is a reversible factor like surgery with general anesthesia, bed immobility, trauma, then you don't require to continue anticoagulation beyond 3 to 6 months. But if there is no obvious cause or the patient has got antiphospholipid syndrome, then you need to continue with the anticoagulation beyond 3 months. In pregnancy, it's a different ball game, and it has to be a teamwork because it's a very sensitive issue. You cannot give oral NOACs, and there are some different criteria for pregnancy, and the safety of the child is also at stake. Low molecular weight heparin is the preferred drug, and it should be continued till the end of pregnancy. You know the warfarin problem with pregnancy, early and late pregnancy, and it has to be by a multidisciplinary team. And the follow-up strategy after anticoagulation 6 months, you have to assess the patient. If the patient is still symptomatic, then you look for whether there is any alternative cause for symptom. If you find an alternative,
2 minutes left.
Yes, sir. If you see there is an alternative cause for symptom like elevated NT-proBNP, risk factor for CTPH, abnormal CPET, if these are present, you continue with anticoagulation. If these are not present, then you look for alternative cause of dyspnea, and there is a high probability of pulmonary hypertension. Then VQ scan, again, if there is mismatch, you continue with indefinite period for long-term prophylaxis. This is my last slide. I'll stop over here because COVID-19 has put us into a renewed challenge of venous as well as arterial thromboembolism. But as I can see, there is Dr. Manoria has very rightly put a completely separate topic for COVID-related thromboembolism. So I won't go into the details of this, but this is very, very important and relevant in today's context. So I stop over here, my friends, and I request if there is an echocardiography related question. I am not very good at echocardiography. Dr. Vijay Lakshmi is there with all the graces in her possession. So please direct the question to her. Otherwise, I am there.
It was a very nice presentation. Congratulations, Dr. Saumitra. You have covered everything very nicely. Since there is a topic of COVID associated thrombosis, I would just like you to give us your view on this, if possible, and whether you would prefer dabigatran or apixaban. Is it because with COVID, your levels of DOAC, direct oral anticoagulants, are increased. So safety is a great factor. Plus, we have seen a couple of patients whom we, for pulmonary thromboembolism, they were given rivaroxaban, and then they came with a bleeding in the CVA, a cerebrovascular bleed. So,
yes, Dr. Pandit. Yeah, I think that the subject will be more covered, but I give my views over here. I think over the last 1.5 years, we have learned a lot. And actually, we learned that how little we knew. Because we have seen cases in front of me, people are doing ultrasonography, and clot is forming in front of their eyes in the inferior vena cava. And they are propagating. Even the patient is on full therapeutic dose of heparin. Clots are being propagated in front of the investigator's eye, and the patients are collapsing. Patients are coming with priapism in the clinic with all the embarrassing situation, and they are falling dead like anything within 5 minutes. So these things we are seeing, and we are seeing how ineffective is the standard dose of heparin is there. 1.5 to 2 times of activated APTT, we are keeping the heparin, still the patients are having propagating clot. So it has put us to a challenge situation. Do we know enough about anticoagulation therapy? Now, as you said, there is very contradicting reports by the active trial and other trials that whether we should give prophylaxis, rivaroxaban or dabigatran in patients. Actually, today, if I say on 4th of July 2021, prophylaxis anticoagulation has got no role. Maybe it will change next week. But if the patient has got proven thrombosis or a high chance of thrombosis, which you cannot prove because the patient is moribund to take to the laboratory and so on, then you give him full doses of treatment, not prophylaxis. Otherwise, when the patient is discharged from hospital, there is a recommendation, if the D-dimer is more than 2 times the normal, then perhaps you should keep the patient on oral anticoagulation for 30 to 39 days. And they are recommending rivaroxaban 10 milligram or dabigatran 110 milligram BD or apixaban 2.5 milligram BD. But it is controversial, sir.
Yeah, and
Dr.
I think
Saumitra Ray?
renal function is a problem. Renal function.
Yes, Dr.
Dr. Asha Murthy from Chennai. Good morning. How are you, sir?
Thank you, madam. I'm good, sir.
Yeah, it was a very nice and very crisp and lucid presentation. I want to know that I had come across some patient who came with a full trimester, third trimester, and they came with acute pulmonary embolism. In such situation, how will you manage? Do you have to give thrombolysis when you document the thrombus in the pulmonary artery, main pulmonary artery, and patient is in the stage of labor? So in such situation, how will you manage such patient?
Madam, here thrombolysis is not recommended at all. You can have a peripartum hemorrhage, the retroplacental bleed, and you may lose the baby. So here, I think if possible, surgical thrombectomy is the goal. If you can do it, otherwise treat her conservatively with full dose of heparin. Heparin is very well given in this situation. You control. Try to get an early delivery so that the baby is out by cesarean section within half an hour if the baby is viable, and then treat the mother fully, because you have to have a very double jeopardy over here. But thrombolysis when the baby is in is not recommended, madam.
With this, we pass on to the next session, and the next session is on lipidology. The chairpersons for this session are Dr. Ashok Tehlani from UK, Dr. Abhishek Singhai, and Dr. S.K. Parashar. I'll hand over the mic to the chairpersons to conduct this session.
Hello. Hello. Are you getting my voice?
Yes.
Yes, sir. Hello.
Yes, yes, sir.
Hello.
Yes.
Audible, sir.
Okay. I've got opportunity to introduce Dr. PC Manoria, who is a living legend in the field of cardiology. Dr. PC Manoria is a well-known cardiologist in our Madhya Pradesh as well as in our country. He has been having the head of the department of the cardiology in the Gandhi Medical College in the past. Then subsequently, he has attained the greatest position in various cardiological societies like Cardiological Society of India, Indian College of Cardiology, Asia Pacific Society of Cardiology, and so on. He has received several awards and orations by Bharat Ratna, Honorable Shri APJ Abdul Kalam, and other awards like this Best Cardiologist Award in Madhya Pradesh. He has organized World Congress on Cardiology. He has written and edited 33 books and published so many publications and delivered more than 600 lectures. I will invite Dr. PC Manoria on a very burning topic, the recommendation for lipid lowering therapy in a very high risk patient with contest to acute coronary syndrome. I will request Dr. Manoria, please deliver your lecture.
Good morning, everybody. For the next 18 minutes, I'll be talking on this upcoming topic, recommendations for lipid lowering therapy in very high risk patients of ACS. All of us know acute coronary syndrome results from disruption of a vulval plaque with superimposed thrombus formation, resulting in occlusion of the culprit artery. If the culprit artery is subtotally occluded, this results in unstable angina or non-STEMI, and if it is totally occluded, this produces STEMI. Although ACS manifests as a thrombotic episodes, the underlying initiating culprit is LDL cholesterol, and unless this is targeted, the outcome cannot be optimized. We have a panoply of strategies to manage ACS, antithrombotics, PCI, pharmacoinvasive, and several other strategies, as you can see on the slide, but lipid modulation is an integral part of management of ACS. It is also very important to remember that the treatment of culprit artery lesion by an interventional cardiologist is not self-sufficient for holistic management of ACS. Following a successful PCI and stenting of the culprit lesion, approximately 12% of patients develop MACE from a non-culprit artery lesion during their 3 years follow-up. The risk of recurrent ischemic events, don't forget, is maximum in the first 30 days, and therefore all possible strategies should be utilized during this period. Lipid modulation targets both the culprit as well as the non-culprit lesion and improves acute as well as the long-term outcome of ACS. Rather, it is mandatory throughout the history or throughout the course of acute coronary syndrome. Now, there are 3 issues in lipid management in ACS. First, you have to categorize the ASCVD risk of the patient and then choose the target for him and then try to reach the target by drugs. Now, this is EAS and AHA-ACC guideline. The very high risk in ESC is documented ASCVD in any of the territory, diabetes with target organ damage, or at least 3 major risk factors, or early onset type 1 diabetes of more than 20 years, severe CKD score more than 10, and FH with ASCVD or with another risk factors, while polyvascular disease is a criteria in AHA-ACC risk for the very high risk group. And the targets are less than 55 in the very high risk with the ESC and less than 70 in the ACC guideline. But the Lipid Association of India Expert Consensus 2020 had made a new category of extreme high risk. Now this shows the memory lane of LDL targets from 1988 to 2020. And as you can see, the LDL targets are being sliced down slowly and slowly. And according to the Lipid Association of India, the extreme risk category A, the LDL target is less than 50 with an optional goal of 30, and category B, less than 30. So what is the meaning of this extreme category, category A and category B? Category A means that you have a CAD with greater than 1 feature of high risk group, that is more than 3 major ASCVD risk factors, 2 major ASCVD risk factors with greater than moderate risk for unconventional risk factors, or greater than other high risk features. And category B means you have a polyvascular disease, you have ACS occurring even when your LDL level is less than 50, and more than 1 feature of a very high risk group, which means a pre-existing ASCVD or diabetes with 2 other major ASCVD risk factors or FH. Now, what was the necessity of creating this extreme risk group by the Lipid Association of India? Now, when we look at the IMPROVE trial, 32% of patients in IMPROVE trial continue to have events with LDL 53, and 12.5% in the ODC trial continue to have events despite low LDL. So the question arises, what are the characteristics of these patients who continue to have cardiovascular event despite very low LDL levels? And when we look at the TIMI risk score for secondary prevention, you can see these are the 9 risk factors. And when we apply these 9 risk factors, I'll show you for the IMPROVE trial what would be the results. But what is important is that if the risk is, these risk factors are 0, the 3-year mortality is only 3.5%, but all the 7 risk factors are present, the mortality mounts up to 58%. So when we apply this Sic Score to the improved trial, you can see the low risk category is when there's only one risk factor, the intermediate risk is 2, and the high is 3 or more than 3. In the low risk factor, you can see only 14% develop CV events. In the intermediate risk, 19% develop CV events, and in the high risk, as much as 34% develop cardiovascular events. And the greatest benefit is seen in the high risk group, about 6.3%. In the intermediate risk, you can see 2.2% with NNT 46, and in the low risk group, 0.9% with NNT 111. And the highest risk NNT was only 16. When we categorize patient according to the vascular bed in the ODC outcome trial, you can see in patient with disease in the 3 vascular bed, 26.7% develop vascular events. In 2 vascular territory, 20.3%, and in 1 vascular territory, only 8.6 develop vascular event. And the greatest benefit is in the 3 vascular bed, about 13% absolute risk reduction. So based on this, the Lipid Association of India 2020 categorized this extreme high risk group with the LDL target of less than 50 for the category A of the extreme high risk group, and for the category B less than 30. And we can achieve these targets by statins, ezetimibe, and the PCSK9 monoclonal antibody. The strategy is usually to first have statins, gold not achieve ezetimibe, and then PCSK9 inhibitors. Lower is the LDL levels, more is the benefit. But while we are targeting LDL cholesterol, you must be very clear about the nuances of LDL. And the first thing you should be very clear is LDL has a causal relationship with the ASCDEE. It is the primary target, and non-HDL is the secondary target. The first issue is lowering of LDL is very, very safe. The side effects which are encountered during lowering of LDL are not at all related to lowering of LDL. They are related to the drug. So if you come across diabetogenicity, you come across muscle side effects, they are not related to LDL lowering, they are related to the drug. Other thing is patient with double loss of function mutation PCSK9, they have very low LDL, 14, 15, 16, they are totally healthy, fertile, no cognitive decline. And if you look at the data of the 4-year trial, 2% patient has LDL less than 10, ODC 7.5% has LDL 15 and improve it, 6% has 30, but no side effects were noted. So the first big message is, don't be scared of lowering LDL to very low levels. It is very, very safe and provides a lot of benefit. This is the data of loss of function mutation of PCSK9. You can see LDL 15, LDL 14, and all these individuals are very healthy, fertile, with good cognitive function. The other thing you must remember is that the LDL in the blood do not cross the blood-brain barrier, and the brain cells are capable of manufacturing their LDL for their function. So that should not be the issue. And here, as you can see, LDL levels lowered even up to 20 is very, very safe. The other thing is, in the statin era, we had the dicta, LDL, lower is better. In the PCSK9 era, we had dicta, super low LDL is better than lower LDL. And the correct dicta is LDL, lowest is best, as shown by the PCSK9 trials. The other nuance you must remember is, start lowering of LDL at the earliest, treat aggressively, and produce sustained lowering to avoid the harms of cumulative exposure. And here you can see classically illustrated in FH that if you initiate LDL lowering therapy at a later date, the threshold for CHD decreases. If you initiate at an early, the threshold for CHD is dramatically changed. The other thing to remember, particularly in diabetic patients and in metabolic syndrome, is that patients with similar LDL levels can have different number of LDL particles and therefore different pathogenicity. Here you can see both these patients, LDL 130, but look at the non-HDL, which reflects the LDL particles, 148 in one and 180 in another. The other issue you have to remember is that if the baseline LDL is above 100, it decreases mortality, provides mortality benefit as has been shown by statin trial. But if the baseline LDL is below 100, it only produces reduction in cardiovascular events as shown by the PCSK9 trials. And the big issue is, if you want to arrest the progression of atherosclerosis, you have to slice down LDL to 65 or 60. And if you want regression of atherosclerosis, the LDL has to be sliced down to 50 or less than 50. And this is beautifully shown by both these trials. The reversal trial shows that we can arrest the progression of disease, and the GLOVE trial with the bubble problem on the right side of the screen showed that you can regress atherosclerosis. And in the statin era, we've already seen that statins are powered to decrease LDL by 1 millimole, and this translates into reduction of cardiovascular events by 20 to 24% as shown by the CTT meta-analysis, irrespective of the baseline LDL. Even if you initiate statin at very low LDL, as you can see here, the benefit is nearly same. And statins, no doubt, are very, very safe drugs. So what are the multifaceted actions of statins? Statins, they improve endothelial function, they decrease LDL and delipidates the plaque, which can be beautifully seen by vascular MRI. This is before statins and this is after statin. You can see the plaques are delipidified. Any therapy which delipidates the plaques will improve outcomes. And the same was shown in the yellow trial, that you can see the lipid core burden index is decreased after a few weeks of statin therapy. The hot plaques, the vulnerable plaques are hot plaques. And if you use statins, this is a PET CT showing a hot plaque. If you use statins in these patients, this plaque is passivated and you can see the change on the repeat PET CT. They also promote calcification of the plaque, stabilize the plaque, decreases cardiovascular event. And the big message coming from here is that if the patient is taken statin, do not use calcium scoring. It is going to be fallacious. And they have a panoply of pleiotropic effects, as you can see on the screen. And what is not often publicized is that the statins decrease thrombogenicity of the blood. So in the event of a plaque rupture, the probability of developing an acute coronary syndrome would be increased if your thrombogenicity of blood is more. 1 out of 10 plaques only culminate into an acute coronary event. And because statin decrease thrombogenicity of the blood, the probability will be minimized. And when you are targeting these patients, don't only look at the vulnerable plaque, you also look at the vulnerable blood and the vulnerable myocardium. And what is also very, very important, statins produce a legacy effect. You take statins for 5 years as shown in the BOSCOP and enjoy the legacy benefit for the next 20 years. You can see here, CHD mortality, all-cause mortality, revascularization, heart failure, all showed a statistically significant reduction after 20 years. In ACS patient, this is the miracle trial, and statins high intensity were initiated 24 to 96 hours of onset of ACS, and you can see a statistically significant reduction in the ischemic endpoints, a 16% reduction. And worsening angina with new objective reason of ischemia requiring urgent rehospitalization was also decreased significantly. And the PROVE-IT trial also showed a 16% reduction in the ischemic endpoint, PRAVA 40 versus the TORVA. And the EuroHeart study again showed that the all-cause mortality is 7 days was significantly lower in group receiving early statin therapy. And this is the Armada ACS. If you use peri-procedural atorvastatin, you can decrease the MACE and peri-procedural MI. And this is the subgroup analysis of PROVE-IT. TB20 again shows MACE can be decreased by statin, TBR and non-TBR can also be. The yellow trial I've already showed you. And these are the pleiotropic effects of statins. So statin is a class 1A indication for all patients of ACS. It should be initiated right at the onset of acute coronary syndrome. And statins, as we've already talked, they produce multiple beneficial effects. They modify the plaques, and if you will bring LDL to lower level, they can arrest progression of atherosclerosis and even regress atherosclerosis. So these are the utility of statins, which we have already talked about. They must be initiated right at the onset. High intensity statins, greater benefits in STEMI compared to non-STEMI, and they must be given 1A therapy. If the goals are not achieved, you can add ezetimibe, as was shown in the Improve IT trial, showed LDL lowering of 53 compared to 69, a 10% reduction in the primary endpoint, and you can see non-fatal MI reduced, non-fatal stroke reduced, revascularization. The benefit was particularly seen in diabetic patients, and this is a precise IVUS with ezetimibe showed regression. Now, if your goals cannot be achieved with statins, again, we use ezetimibe, and this is a 1B indication. PCSK9 are the wonder molecules which have revolutionized the treatment of lipid management in ACS and other subsets. All of us know how does PCSK9 acts. The normal function of PCSK9, this blue one is PCSK9, is to bind to the LDL particle and LDL receptor. The LDL receptors, the LDL particle is cleared in the hepatic cells, and the LDL receptors undergoes lysosomal degradation and cannot be recycled. Their number decreases, and therefore LDL levels increases. But if you block the PCSK9 with PCSK9 monoclonal antibodies, then the LDL receptors are free to bind to these particles, taken inside the hepatic cell. LDL is cleared, the receptor is recycled again and again, and that increases the number of LDL receptors and more cholesterol is lowered. PCSK9 are no doubt more powerful than statins. They decrease LDL by 60% or 65%. And what is very interesting is they favorably modify all the components of lipids. ApoB decreased by 45 to 55%, LPA 25 to 35, VLDL 30%, and HDL is also elevated 5 to 9%. This is the 4-year trial. All of us are aware of it. A secondary prevention trial in patients with stable coronary artery disease, and the ischemic endpoint reduced by 15%, but as I already told you in the earlier part, no change in the mortality. And this is the primary endpoint. The curve takes about 6 to 8 months to separate. And more qualifying MI, less than 2 years, the benefit is more, as you can see on the left compared to the right. If there are more than 2 prior MIs, more benefit on the left compared to the right. And if you have multivessel disease, more benefit than no multivessel disease. Lower is the LDL cholesterol, more is the benefit we've already talked about. And this is the ODCE outcome trial. Post ACS, mind you, the patient was enrolled 1 to 12 months after ACS. What is very, very important to realize is that even when you use PCSK9, the curves in ACS start separating after 1 year. And this should always be remembered. And as we said, PCSK9 trials have not shown reduction in mortality, but the baseline LDL was less than 100. But if you analyze the data, ODCE with LDL more than 100, there was a reduction in the all-cause mortality. This is the AVOPEX trial, which initiated statin during the hospitalization phase. It was not powered to determine the outcome, but showed that LDL can be substantially reduced here, 77%, and has good safety. So statins can be initiated. This is a Japanese trial, again, AVOPEX. You can see RCT in this Japanese patient receiving pitavastatin and patient going for PCI. Substantial number is receiving goals, LDL less than 70 and even less than 35. And this is another AVOPEX trial in STEMI, non-STEMI patients undergoing PCI. Again, you can see substantial benefit. The guidelines recommend statins as the initiating therapy. If goals are not achieved, wait for 4 to 6, initiate ezetimibe. Goals not achieved, wait for 4 to 6 weeks and initiate PCSK9. But the problem is, as I already showed you, the curve starts separating after 1 year. If you waste 4 to 6 weeks after statin, 4 to 6 weeks after ezetimibe, you are getting benefit after 15 months when the maximum incidence of recurrent events is in the first 30 days or in the first year. And therefore, although the guidelines recommend this, but if you are coming across patients who have a very high risk curve, they should be initiated right at the onset of ACS, although there could be difference of opinion. So patient with multivessel disease who will have more ACS, more infarcts, more recurrent revascularization, even CAVG, recurrent MI, again, you will have more revascularization, stenting, CAVG, post-CAVG stenting, young patients who have recurrent events in the long run, polyvascular disease, raised FOB, raised LPA, FH, all these are very, very high risk patients, and PCSK9 should be initiated at the earliest rather than waiting 6 weeks after statin and 6 weeks after ezetimibe. These are the beneficial effects we've already talked about. Inclisiran, the beauty of inclisiran is that a single dose, 300 milligram, decreases LDL by 50%, and this remains there for 6 months. although inclisiran has not been tested in ACS, has been tested in ACD, but I'm sure in times to come, they will be tested in this subset of patients. So what are our achievements? Moderate intensity statin, you can slash down LDL by 30%, high intensity statin 50%, high intensity plus ezetimibe 65%, PCSK9 60%, PCSK9 inhibitor plus high intensity 75%, and all three drugs by 85%. So we are powered with very effective drugs which can reduce LDL cholesterol to very low levels. So what are our achievement of war against lipid with these new weapons in the high-risk ACS? When we talk of the issue of can we stabilize the plaque, answer is universally yes. Yes, statins alone are powerful in this. Can we reduce the build-up plaque, that is arrest of progression of atherosclerosis? The answer is again universally yes, and has been elegantly shown by the reversal trial. And when we talk of can we shrink atherosclerosis plaque, that is regression of atherosclerosis, the answer is universally yes, as beautifully shown by the glove. But when we talk of the issue, can we make the plaque disappear from the vessel wall? This is a big unanswered question to be resolved in future. But at the moment, the answer to this question is no. So in summary, ACS has a very high morbidity and mortality, and the risk of recurrent ischemic events is highest in the first 30 days. All strategies must be utilized early in ACS to have the maximum benefit. Besides antithrombotic therapies and PCI, lipid modulation is an integral part of treatment throughout the history or throughout the course of acute coronary syndrome. LDL targets depend on the category of the risk, and LDL lowering should be initiated at the earliest, and even very low LDL 10, 20 are very, very safe. And LDL target should be reached at the earliest in the extreme high risk group, which I've shown by high intensity statins, ezetimibe, and PCSK9, and RCTs with outcome data required in ACS. We don't have RCTs in the in-hospital phase. The OTCS after 1 month, right at the time of admission. Thank you very much for your kind attention.
Thank you, Manoria sir, for your enlightening speech. Sir, one question from my side. How to manage dyslipidemia in pregnancy?
If you have dyslipidemia in pregnancy, you can use resins, other drugs, and lifestyle modification. If it is a case of FH, you can resort to LDL apheresis also. Mepomarsin, although not widely used except in FH, has been granted category B, although they are, which means there are no any trials. Resin is the best answer together with lifestyle modification, and if you have FH, you can resort to LDL therapy if the LDLs are very high.
Dr. Manoria, this is Dr. Asha Murthy from Chennai. Good afternoon, sir. It was such an excellent presentation and such a difficult topic you had covered and precised in a very 18 minutes. Again, covering all the studies. I think we had a brief of very good presentation. I just wanted to know that what is the role of pitavastatin in dyslipidemia? Because we are not using pitavastatin in a practical day-to-day practice. Mostly we are using statins, Rosva, atorvastatin, esezimide, and pitavastatin has not come into a role, or sarcoglycan also we are not using it. So what is your clinical experience regarding this utility of this drug?
Pitavastatin is a moderate intensity statin, and its specific indications are if you have a patient with statin intolerance, you can use pitavastatin 2 milligrams with ezetimibe will be a very useful combination. It does not have diabetogenicity, as has been shown in a trial that if you initiate pitavastatin in IGT, the diabetogenicity is not there. And thirdly, it is also safe in CKD patient. It has been shown to increase the eGFR compared to rosuvastatin, which has an adverse effect in CKD. Atorvastatin is also safe.
Dr. Manoria, I have got question that what is the current status of LPA, and also you tell the what is the evanucumab, which is approved by US FDA or not? What is the current status of the LPA?
LPA, all of us know, is genetically determined. It not only has an atherogenic potential, it also has a thrombogenic potential. That's why PCSK9 studies, which has elevated LPA, has shown decrease in VTE also. The higher the level of LPA, more is heterogeneity, lower is the level of LPA, less is the heterogeneity. Nicotinic acid decreases LPA, but this is not available. PCSK9 decreases LPA by 25%. The Horizon trial is ongoing with antisense agent against ApoA of LPA to see whether lowering of LPA without changing the LDL levels would benefit. The results are going to be out in 2020 and 24. And if the trial comes out to be positive, then only we will have an evidence-based recommendation for LPA. At the moment, the recommendation for LPA is an expert opinion and not an evidence-based, and do not have an evidence-based target for LPA. Regarding your question of evanakimab, it is an angiopeptin-like 3 antisense agent, which is approved by US FDA early this year. It is very useful for homozygous familial hyperlipidemia because action is independent of the LDL receptors. All of us know in FH, homozygous LDL receptors are not active. So even if the LDL receptor activity is very less, this drug is effective, and this is the beauty of this drug.
Lastly, I want to ask, do PCSK9 have the legacy effect, PCSK9 inhibitors?
Statins have legacy effect. There's no data as such for the legacy effects of PCSK9, but it is possible after a few years this data may be analyzed. But at the moment, no such data.
Dr. Manoria, this PCSK9 inhibitors, which has a role in venous thromboembolism. Does it have any role, or any trial was done?
I told you, PCSK9 because it decreases LPA. The follow-up of the PCSK9 trials have shown that VTE was decreased only in those subset of patients whose LPA was elevated. And the explanation is obvious because LPA not only has an atherogenic potential, it also has a thrombogenic potential. So that's why the reasons. So it has a role in VTE, and in future you may have separate trials to test PCSK9 in patients with VTE. But that's no dedicated trial.
Now we stop the discussion, and thank you very much, Dr. PC Manoria, who has given a very lucid and informative talk about the lipid lowering agent in the high-risk patients of the dyslipidemia. Now we will move on to next.
The next session is on COVID coagulopathy, and the chairpersons for this session are Dr. Aziz Khan from Nagpur, Dr. V.P. Pandey from Indore, and Dr. M.C. Agrawal. Dr. Bajan Khusrav is very near and dear to us. He has a masterly approach of slowly unmasking the depth of the problem. He is a consultant critical care and head emergency department, PG Hinduja Hospital and MR. He has around 20 years of experience, has more than 25 national and international publications, and he's co-author of the Textbook of Emergency and Trauma Care published by JP in 2017, received several awards and orations. He's organizing chairman from MCON 2004 and 14, and he's an AHA and ACS certified instructor for ACLS and ATLS respectively, and his areas of interest are trauma, disaster care, antibiotic stewardship, MV strategies, and AG analysis. He's talking on a very interesting and a current topic, that is COVID coagulopathy, and I hand over the session to the chairpersons to conduct this session. Dr. Aziz Khan.
Thank you, Dr. Manoria. I think we are coming to a very important topic now, which Dr. Roy started initially, because most of the COVID deaths are occurring because of thrombogenic complications. After the pandemic is over, almost over, we are getting more patients with post-COVID complications. Patient coming with pulmonary embolism, patient coming with stroke and MI. We want to know Dr. Khusrav, because he has been looking after Hinduja and many cases of COVID, his own experience, how they are managing these patients. So may I ask Dr. Khusrav to start his talk?
Thank you, sir. Are my slides visible?
Yes, sir, your slide is visible.
Yeah.
Dr. Manoria, thank you so much for having me over once again. And it's absolutely a pleasure to be with you when we have a conference of this high accord. In the 1.5 years of the COVID pandemic, as we have been grappling and fighting this COVID pandemic, many things have become a little clear after 1.5 years. One thing that is extremely clear is that we have not many drugs which would help us in treating COVID, and what does not work is very clear, and what works is a little less clear. Of the medications that we use besides a good ICU practice are the low molecular weight heparins or the anticoagulants or thrombotics and the steroids that have been here to stay in the last 1.5 years. So let me take you through the journey of COVID and its association with thrombosis and probably the way ahead in this situation. So let me see whether there is a big problem here or not. And yes, COVID and VT and even arterial thrombosis is associated in a 1/3 number of patients, and it is a big number here. The spectrum would be different, not only from the venous thrombosis, which we know because of increased fibrinogen, the activated coagulation, the enhanced platelets, but also the arterial thrombosis at the other end and leading to strokes and acute coronary syndrome, as the chairperson mentioned. And then in between, we have the microthrombi, which also affect our patients. And this is because of intravascular coagulation, which may be localized or disseminated. So how does thrombosis occur in COVID? And I think this is the big spectrum of the thrombosis that we have seen in COVID more than any other disease so far. So it affects both the small and the large vessels. It can cause DVT, pulmonary embolism, blocked renal circuits in patients who are on CRRT, line-related thrombosis, arterial thrombosis. We've seen CVAs, MIs, and peripheral arterial disease very commonly, not very commonly, but yes, we have seen it with COVID. We've seen microvascular thrombosis leading to purpura fulminans. We've seen cortical vein thrombosis as a presentation, mesenteric ischemia, and even some cases of retinal artery thrombosis. And I'm sure I've missed out 1 or 2 other presentations because the list goes on. So why does thrombosis occur in COVID so commonly? So as we know that the SARS-CoV-2 would affect the dams, it would affect the tissue and cause damage. It would affect the glycocalyx and then the neutrophils, and the entire coagulation cascade would be affected, leading to finally a fibrin and a thrombin formation. What is important with COVID and what is different is as the severity of COVID increases, the thrombotic risk also increases. So as you can see in this chart here, in the mild COVID, you almost don't have much of a presentation of thrombosis. But as you have a moderate COVID, in the second graph here, you will see that there would be a small proportion of increase in the pulmonary coagulopathy and thrombosis. Reduced coagulopathy gradually happens once the disease gets better. But on the right, as you can see in severe COVID, the entire spectrum will continue to propagate itself, and the thrombosis even lasts, again mentioned by our chairperson earlier, is that it again continues even in the post-COVID era after discharge. So what do we look at to stratify these patients? In the ICU, we must look at the SIC score, and that is the sepsis-induced coagulopathy score. So this takes into account 3 factors, and that is the platelet count, whether they get 1 and 2 points, if less than 1 lakh or 1.5, and if less than 1 lakh, then it gets 2 points. Similarly, they look at the INR and the SOFA scoring system, which is a sequential organ failure assessment scoring system in sepsis. And if a score is more than 4, this patient has a very high tendency towards thrombosis. The earlier studies from Wuhan, there were 6 studies which also said that if the D-dimer is risen by about 3-fold from the baseline, then there is a 3-fold higher mortality, and that is almost 30% instead of 11% in these 6 studies. And therefore came a big hype about doing the D-dimers almost on a daily basis, and I will discuss this in a bit, why it is not so important. The subsequent studies did not show a very good correlation between mortality and D-dimer, but yes, we know that it is one of the markers that we would like to look at in the setting of COVID and thrombosis, and the other one being fibrinogen and the platelets. So if you look at the D-dimer, the fibrinogen levels and the platelet levels, then we would definitely know that these patients have a coagulopathic and a thrombotic tendency. And here again, the pathophysiology shows that it's extremely important for us to risk stratify, to know the inflammatory response, as I mentioned earlier, along with the other biomarkers. We may take help of the interleukin-6 and the CRPs, which are very important here. And then the clinical outcome needs to be identified with a high level of suspicion. So in a nutshell, for the pathophysiology, there are four main things that happen: activated coagulation, endothelial damage, fibrinolytic suppression, and then thrombocytosis and platelet activation. And all of these would lead to a high tendency of thrombosis in COVID. So is this a real big problem? And I have put up many studies which actually just look at the last part, and that is the chance of VTE can progress in COVID from 15% to 49%, from 20% to 70% in many studies, and so on and so forth. And therefore, a correlation of all these articles of 425 studies, 42 studies, etc., would give us big figures of thrombosis in COVID. And that is an overall VT rate of 21%. In the ICU patients, a 31%. In the DVT rate was 20% similar, and post-mortem was 35%, and so on and so forth. And the pooled odds mortality was 74% higher in patients who developed VTE compared to those who did not. So this is very important. Developing a VTE is okay, but those who develop VTE is not okay, but it is all right. But developing a VTE and having higher mortality is extremely dangerous, and therefore it's important for us to note this at the beginning. And therefore, they also realized that those group of patients who received low molecular weight heparin had a decreased incidence of VT in this study from 16% who did not receive it to 8%, nearly half. And this brought about a big hype in many newspapers about the D-dimers, about the strokes that happened, the link in the UK Indian strains, the state approves a blood thinner for treatment, and so on and so forth, a mysterious blood clotting complication, and the works. When we use an antithrombotic in COVID, we need to understand the three phases of COVID. The initial phase in the first week is usually the viral response phase, and then later on in the second week has the host inflammatory phase, and therefore in between we would have the pulmonary phase. So too early or too late would be inadequate treatment, and we need to try to get the right dose at the right time in these patients. So before we move on with the studies, we need to understand the three doses that we use when we talk about enoxaparin or low molecular weight. When we say standard dose, it means 40 milligrams of enoxaparin, irrespective of the weight of the patient. When we talk of an intermediate dose, it is 1 milligram per kilogram subcute once a day. And in the therapeutic dose, it is 1 milligram per kilogram subcute BID. So for a 100 kg person like me, you might want to give 100 milligrams twice a day, which is so high. Now let us look at all these guidelines, and I've tried to collate this so that it makes it easy for us to understand what we are dealing with. Let us start with the Indian government guidelines, and they have made it very simple. If it is a moderate COVID, use prophylactic dose, and if it is a severe COVID, then you might use a high dose. But then all the international studies have refuted this, and they have come to a different conclusion, which I will just talk about. Besides these societies, there have been various studies which have been undertaken as regards therapeutic dose, which is double the dose I mentioned, as regards a standard dose. And those are the REMAP, CAP, the ATTACK, and the Active 4A categories. And the bottom line of all these is that majority of them recommend a thromboprophylactic dose only for all hospitalized patients, with exceptions whenever the patient has a problem of VT. And even the American Society of Hematology has suggested that the prophylactic intensity is far better than the intermediate or the therapeutic intensity. So yes, it is a problem, but don't get carried away and start giving very high doses of low molecular weight or anything else. When we talk about AKI, we know that the incidence of AKI can go from 1% to 30% in COVID. The need for CRRT is almost 15%, more common in the ICU settings, and there are many issues with AKI and COVID. And therefore, we have been traditionally told that the dose of enoxaparin or any low molecular weight heparin is not to be used in a renally impaired person. But here you can actually see that the dose modification is done appropriately, then you still could use enoxaparin. That is the only one which is studied. And otherwise, if you are not very comfortable, you may switch over to unfractionated heparin subcutaneously 3 times a day. Now, what about the extended prophylaxis? Do we give prophylaxis to these patients who are discharged from the hospital? And these are the studies which were done before the COVID era, and that is the EXCLAIM study where they studied Enoxa with placebo, ADOPT, which was Enoxa with apixaban, Magellan, Apex and all, and they did not show a benefit of thromboprophylaxis unless given in the high-risk group of patients who would have a VTE tendency. Also, they looked at the bleeding tendencies, and the bleeding tendencies were definitely not higher with the low molecular weight as compared to the NOACs as per most studies. Now, can we extrapolate this in the COVID scenario? We'll just talk about it. And as Dr. Manoria said in one of his slides, it will be an expert opinion more than evidence-based. So let me just put the summary guidelines here from the NIH, which are the latest. And they say that in non-hospitalized patients with COVID, there is no data to support the measurement of coagulation markers, D-dimers, fibrinogen, etc., A3 evidence. And that's quite interesting because most of the general practitioners ask for about 15-20 biomarkers in a patient who turns out COVID positive or even inconclusive. In the hospitalized patients, yes, we need to do all these markers and we need to understand the severity of the illness. In chronic anticoagulation and antiplatelet therapy, if the patient has been on it, then do not stop it and continue it. But that does not change the picture in these patients unless they have been cases of VTE and DVT prior to the COVID. And this list will go on, but I will just bring you to an important part here, and that is what do we do when we have a pregnant or a patient with lactation? And there is studies that you need to treat them similarly to the patients who are non-pregnant, but in the cases of extended prophylaxis and in lactation, do not use a NOAC and prefer a low molecular weight. So what is the way forward? We definitely need more data and more data from India. We do not overuse and abuse biomarkers for non-hospitalized patients because that confuses us. We follow evidence-based guidelines. We individualize the care decisions. Every patient is different and has a different risk, and therefore we may look at high-risk patients. We do not only depend upon low molecular weight or any other heparin, but we need an urgent avenue for activated protein C, PAIs, tissue plasminogen activators, and then we look at something called as POCUS, and that is the point of care ultrasound and echo. So this is very interesting, and I would take just 1 minute on describing what is POCUS. So we have we have been using POCUS in the ICU for at least 10 years, and we have realized that you can actually look at the fluid status of the patient, you can look at the cardiac status of the patient, the lung issues, pneumothoraces and whatnot. But in the COVID scenario, there is a stepwise approach. You can do a cardiac USG, you can do a lung USG. And what is important is my friend and me, Dr. Kedar, we have been doing this ultrasound in these patients of COVID. And many of them, even before developing thrombosis in any form, have smoky vessels. So you look at the vessels and you see a smoky appearance. These are the patients who might develop VTE later. So this is a nice diagram. And as you can see, see a lung ultrasound score of 11 versus 27, and this would actually guide you towards the management of ARDS along with low molecular weight heparin. So my last slide, in summary, thrombosis in COVID is common. At least 30% of patients of COVID can develop some form of thrombosis. Stroke and acute coronary syndromes are common presentations. Thrombosis is linked with severity of disease. Risk stratification should always be done. A high suspicion is a key. Unexplained worsening, this is important. Unexplained worsening of the PF ratio and the hemodynamics should be investigated. So somebody who's improved in ARDS, somebody's sepsis, which is better, now suddenly has a decreasing PaO2 FiO2 ratio, is hypoxic and is hypotensive. Please do a CTPA and try to rule out a PE. Standard dose is always preferred